Hi, good evening, everyone. Welcome to part 2 of our Teoxane Eye Rejuvenation webinar series. I hope you're all feeling bright-eyed today because we got a really exciting session lined up for you. I'm Dr. Nadia, aesthetic physician from Malaysia and now medical education manager with Teoxane. I would really like to first introduce our speaker for today, who is Dr. Tahera Bhojani. She's an international award-winning doctor and laser eye surgeon. Dr. Tahera is from the UK. She's a member of the Royal College of Ophthalmologists and has multiple postgraduate diplomas, namely in dermatology, cosmetic science, and laser skin therapy. Dr. Bhojani is notably known for her passion and love for medical education and also sharing. She's expert in periorbital rejuvenation, but she also treats other areas of the face. And she is known for using advanced injection techniques to lift eyebrows and support the tear trough. So let's kick things off with a quick recap of what Dr. Tahera shared with us in our last month's webinar, where we first explored the complex anatomy of the eye, and Dr. Tahera also guided us through the complex anatomical structures of the eye and also aging process, which helped to guide our treatment approaches. And Dr. Tahera also dished out some really valuable tips and tricks to navigating danger zones at this area. Okay, so enough about the past and let's focus on the present. Today, we're going to dive even deeper into the world of dermal fillers and eye rejuvenation, and also the upper face. But before we get started, let's have some fun with interactive polls. There's no wrong or right answer, but the polls are really an opportunity for us to gauge our collective knowledge and for Dr. Tahera, our speaker, to understand what everybody's preferences are for rejuvenating the eye and upper face and set the stage for today's discussion. So let's have the polls up. So the first question that we have up here, you have to scroll down to reach all the questions. We just have 5 questions. So the first question is for upper face. If you were going to do a rejuvenation and you're using a non-surgical procedure, what percentage of your total non-surgical will be on injectable practice? Okay, so second question is, which treatment option, in your opinion, best enhances the look of the periorbital region? So we have HA filler, RF device, neurotoxin, threads. For question number 3, we have for subtle brow lift using HA filler, which injection technique will you prefer? Will it be like a deep structural focusing on the supraperiosteal, or will it be the superficial? And for question 4, do you practice combining HA fillers with toxin to achieve a lifted eyebrow? And the last question is, what is the preferred product for treating horizontal forehead lines? Will it be the neurotoxin or the HA filler? Okay, quite a fair bit of you have participated. We're still leaving some time open for the rest of you who have not participated before we end the poll.
We're getting some interesting answers.
Yeah, Dr. Tahera, you can see the responses.
Yeah, I'm just looking at them now. Good morning, Nadia. Nice to see you.
Nice to see you, Dr. Tahera, as always. Okay. I think we can end the poll. Yeah, let's end the poll and take a look at the results. Okay, so for the first question, upper face non-surgical procedure, how many percent is injectable practice? I think that's quite an well divided. Some would say less than 20, 20 to 40, 40 to 60, and 60 and more. Pretty average. Any comments there, Dr. Tahera?
This is interesting because in the UK, the commonest way of treating the upper face and that whole area, we would be virtually all injectable. So it's interesting that there are in Asia some people less than 20% will use non-surgical injection techniques for this area. And it would be interesting, maybe some of those that said that they use other alternatives, we could maybe see that in the comments. Somebody could say, yes, because we use something else that gives us a better result. I'm hoping we will be able to share some of that knowledge. So I would encourage whoever's taken part in the poll, and even if you haven't taken part in the poll, just to put some comments on perhaps what you do use in this area. And maybe during the presentation, we will cover it as well, because I'm going to talk about some different techniques that we can use, but they are mainly injectable.
Okay, great. Yes, so for the next question, okay, which treatment option best enhances the look of the periorbital region? Wow, 80% actually says they use HA filler.
So most people think of periorbital as the under eye. They don't actually think about what you can do up here to make this look better. So I think the default position is that we are going to use fillers in the under eye. But of course, there are other things you can do. And interestingly, of the poll that we've had, nobody is using threads. I'm pleased about that because I'm not a big fan of threads in this part of the face.
I'm actually quite surprised with the response, knowing in Asia, predominantly we use threads for other parts of the face. So maybe, I suppose for periorbital, maybe they don't really use threads, majority of the people. Okay, for third question, yes. For subtle brow lift using HA filler, which injection technique do you prefer? Majority, deep structure.
And I'm happy to see this because there are some potential risks of using superficial fillers in this area. And when we talk about the anatomy a little bit later, we'll see why that may be an issue, that it's a little bit more difficult to do that, unless, of course, you're going very, very, very superficial and you're intradermal. So you'd have that super superficial, or you'd have to be deep. The in-between area is a bit of a no-go. We'll come to that.
And I know you have some cadaver videos for that.
Absolutely.
Yes. Okay, so fourth question, do you practice combining HA fillers with toxin, yes or no, or sometimes?
So sometimes, and yes, have it really. And combination treatments, I think, are the way forward in the whole face, but particularly in the periorbital area. And we will be talking about how to combine toxin and filler in this webinar, which is an interesting thing to do. The different aspects of what these non-surgical techniques can do. Just seen a little comment come up saying, I usually go for a surgical approach. So that's a fabulous comment to hear. Well done to the surgeons that have that choice. For those that don't have that choice, but yes, of course, a surgical approach, which we didn't mention because we were just talking about non-surgicals, but for sure, a surgical approach would often be the gold standard.
Right. Yes. Thank you for sharing what you usually do from the surgical context. So that would be good information for us as well. Okay. So
yeah, I just saw somebody's comment come up there on my screen, actually. So I'm assuming somebody in the audience said that. Okay.
So the last poll question, preferred choice for treating horizontal forehead lines will be neurotoxin or HA filler?
So I'm not surprised to see this because most people think lines of animation, we're going to use neurotoxin. But remember, there are some disadvantages to putting neurotoxin in the forehead. and we will talk about the disadvantages and how we can, in those patients that are really not suitable for having toxin in their forehead, things that we can do to improve their forehead lines.
Okay, great. So thank you so much, folks, for participating in our poll. And now that we have warmed up with our polls, let's get down to business. And today's session, I'll just be sharing with you briefly before Dr. Tahera gives us a deep dive. We'll be exploring the various approaches to rejuvenating the upper face and the eye area. And Dr. Tahera will be sharing with us the advanced techniques that she practices in her day-to-day practice, and also pushing the boundaries of what she does with, which is possible with dermal fillers. And as per the Teoxane approach, she'll be sharing based on the ATP method, anatomy, assessment, and sharing her techniques and what products and why does she use these products in her practice. So whether you're a seasoned pro in dermal fillers or just starting out your filler journey, I'm sure there's something for everyone who is participating in our webinar today. So with that, I'll leave the floor to Dr. Tahera for her presentation. So up to you, Dr. Tahera.
Let me just get my screen shared. And I'm hoping you can see my screen nice and clear now.
And yes, we can.
Thank you so much, Nadia, for that lovely introduction and the interesting poll. So I'm going to say good morning, everyone. I know for you it's afternoon there. You've had a busy day at work, and thank you so much for taking the time to educate yourselves on something a little bit different. So those of you that saw the presentation last month, we talked about behind those bright eyes, it was the Teoxane approach to periorbital rejuvenation, and we covered some interesting topics. We covered indirect as well as direct tear trough correction, using fat pads as well as just putting product in the medial tear trough. And we also talked about how to do outer canthal lifts, creating a stretch in the corner of the eye to give a more confluent look to the under eye. Today, we're going to do some more advanced and expert perspectives. We're going to perfect this by going a little bit above and beyond, by looking at the rest of the eye area and how we can use it to enhance the periorbital area. And we're going to use the Teoxane approach, which is anatomy, aging, assessment, ATP. So we're going to do the anatomy. Nobody particularly enjoys anatomy, but if we make it relevant to what we are doing, you might find it a little bit more interesting. We need to know how the structures age, and the most important thing is how to assess. If you assess well, you will inject well. If you see where the defects have occurred, you can replace them. And quite often a defect in one place, like the tear trough, is created by a loss of volume in a different place. And this is the most important thing I want to try and teach you with all of what we're about to do. What you see as the effect is not the same as the cause. And if we look at the cause and treat the cause, we will get a much more natural looking result. So then we look at how to plan your treatment and your techniques, which is part of the ATP. And then we'll talk about which products will give you the best results for the areas that we're treating. So when we are looking at older patients and younger patients, older patients, we discussed last time that looking at the mid-face volume loss and treating the mid-face volume loss before we even address the tear trough will actually give you a much more balanced view of the face. Today, we're going to talk about how blending in temples can improve the appearance of the eye, and how shaping eyebrows can frame the picture. Remember, your eyebrows are the frame of your face. So having a nice defined eyebrow will frame how attractive the face looks. Okay. And just when you look at the shape of the eyebrow, if the eyebrow is not completely visible, what a difference it makes when it is. Okay, and similarly, when we're looking at a younger face, we're looking back at keeping these contours even. So even though she doesn't need her temples treated as such, because this younger patient has had some filler in her outer cheek, it has created the appearance of a temple hollow because of the filler that has been put too laterally in her face. And when we actually smooth that out, how much more attractive the shape of the face becomes. It's less angular and more smooth. So we're talking about how to blend the outer eyes and the temples. We're going to talk about how to smooth these foreheads. Okay, and we're going to talk about how to lift the brows with combinations of fillers and toxin. So let's start with the anatomy. So reminder, we did this 4 weeks ago, but I'm just going to recap with you 5 layers to the face, starting with bone deep, deep fat. These are both structural layers that do not move. So they create the base of the face. Then we have the muscle layer, which is attached to the skin by thin fibers, which is why when we put toxin in the muscle, the movement of the skin alters. So this is a layer where the muscle and the skin are attached, and in between there is subcutaneous fat. And the more fat we have in that subcutaneous layer, the more smooth the face looks. So chubby ladies that carry, or chubby men, people who carry a little bit of fat, their skin looks smoother. It's like having a duvet or a quilt on your bed that is really well stuffed, gives you a very smooth contour and disguises sometimes the aging changes below. Okay, so all of these layers, the structural layers that don't move and the mobile layers that do move, they all age. Okay, and we talked about the aging of this last time. If you missed the webinar, you can go back and review it, because you'll be able to see how important those aging changes through all 5 layers affect different parts of the face. And we also mentioned, specific to this part of the face, while most of the face has 5 layers, certain parts around the periorbital area do not have 5 layers. In particular, the lateral tear trough has 5 layers. We have deep and superficial fat, which is why you can put deep filler and subcutaneous filler here and help create the curve on the cheek and help support the under eye. But in the medial tear trough, in this part of the eye, there is no subcutaneous fat and the muscle is attached to the bone. There is no deep fat. So when you are pushing a cannula into the corner of the eye to try and lift the tear trough, remember, you are not going into fat, you are going deep intramuscular. You think you are under the muscle, but you are actually in the muscle. And if you are putting any product in the muscle is mobile. You need a product that will move properly, otherwise it will encapsulate and become visible. So let's talk about the other areas. We did this anatomy in a lot of detail in the last webinar. We're now going to talk about the other areas. So the adjacent, we did this adjacent area. We're now going to look at this adjacent area, which is the temple. So we talk about a 5-layer anatomy, but the temple anatomy is really quite different. There are not 5 layers, there are 10. Some would say there are 12 layers of tissue that run from bone to skin. And interestingly, the deep fat that sits under the muscle is absent. So you can see there's bone, there's pericranium, which is like a thin layer of fibrous tissue, and then there is muscle. So the muscle is attached to the bone. So out goes the 5 layers in this part of the face, and in comes something very different. Now we know that there is a continuation of muscle from your platysma to your temple. That's why when you stretch here, this looks better. We all love it when we do this because our faces look fabulous. Yep. So you stretch here, this looks better because that SMAS layer, the superficial muscular aponeurotic system, is platysma, all the muscles of facial expression right up to your temple. Okay, so the temporalis muscle is attached to the bone. And then there is, so the only things that are really familiar from that 5 layers, there are lots of layers, but I'm going to try and simplify it, because if you try and remember all of this, it's going to be quite difficult. Muscle is attached to bone. So if you go deep to bone with any product here, are you going to be on bone? No, you're going to be deep intramuscular. Keep that in mind. Okay. The area that does have some fat is that subcutaneous area. So there is a thin layer of subcutaneous fat, which we lose as we get older. And the majority of hollowing that we see in the temple is due to loss of subcutaneous fat. And remember that whenever you have muscles that move, and they move a lot, the subcutaneous fat over the muscles is lost because we preferentially lose fat over areas of muscle movement. Okay, we'll use local resources to provide energy to the muscles, which is why with age we hollow here and we hollow here, because those are the muscles of mastication, and we lose the fat over them because we eat all the time. I eat all the time. So that's an important thing to remember. So if we're simplifying this very complex anatomy and we're thinking this is the layer that is aging the most, then it makes sense to think about replacing the fat here when we are treating temples. Also bear in mind that there are a lot of vessels as we get lower. So there is a small area of fat above the muscle, a little bit more on the deeper layer, with some layers of fascia in between. But actually to access that accurately without compromising vessels is very difficult. So you will see some tutorials or some teachings where they say the safest plane to put filler is actually the intrafacial plane, to put it in between the layers of fascia where there are no vessels. But to actually accurately get your cannula running through those spaces is really quite difficult. You have to be very experienced. So the safest place for an inexperienced injector is layer 2, the subcutaneous fat plane. And we will talk about how to do that. Bony, so aging changes as we go through. We're going to go through those bone, muscle, superficial fat, etc. So the bony age is changing. We discussed this last time. We know the shape of the orbit changes. The temporal bone thins with age. So this part does not thin at all, but this part does. So if you're going to a needle down to bone, you can't go too far back because the bone is so thin, you may actually end up penetrating. And there are reported cases of that having happened. Coming up from bone, we have deep fat. Again, we discussed the medial soup, lateral soup, deep medial fat compartment here. But remember, there is also a deep fat compartment here called the roof, which is the retroorbicularis fat pad. And it sits mainly on the lateral aspect under the eye. And it's what gives sort of curve and flesh to a younger eye. And it gives support to the eyebrow. So when we lose the roof, the eyebrows droop. Muscles around this part of the face, of course, are important. We have orbicularis oculi, big circular muscle, responsible for lymphatic drainage, responsible for blinking. 2 parts, palpebral and the orbital. And then we've got your temporalis muscle, part of your muscles of mastication. It's quite early in the morning here. And we've got then, of course, frontalis, which is the only muscle that lifts the eyebrows. Superficial fat. Now, the interesting thing about the superficial fat pads here is that we lose the one under here quite early. We mentioned that last time. And we have only superficial fat up here. So remember, there is no deep fat in the forehead. There's no deep fat in the temple. It is only superficial fat. So when we are thinking about how we are going to improve the loss of volume in this area, it is actually the superficial fat planes that have diminished. But we also know that there are some dangers of targeting the superficial fat here. So we need to think about clever ways of making the superficial fat look better without actually going into the area where we might have blood vessels. Just remember the names. This is your medial fat. Sorry, this is your central fat pad. And this is your medial fat pad, even though it comes all the way to the lateral aspect of the eye. The names are a little confusing. And of course, then the combination of all of that loss is not just the tear trough, it's also the temporal hollowing, it's also the loss of support under the eyebrow, and it's also the loss of contour of the forehead. Let's talk about those danger zones. So I think anatomy is only interesting if you can actually visualize it. So we're just going to do a few videos and I'm going to talk you through those layers of anatomy, starting with the temple. So top layer is skin. We're just going to lift the skin. Okay, and there you can see that primary layer, which is subcutaneous fat. Okay, so when we peel back the subcutaneous fat, okay, you can see that there are some little blood vessels in the subcutaneous fat layer. Okay, and then you have this fascia, and that layer of fascia actually contains one of the big arteries. So that's your anterior branch of your superficial temporal artery coming across. And the landmark is very easy. You go from the top of the auricle of the ear to the top of the eyebrow. And if you draw that line in, you can see he's just demonstrating there, top of the auricle of the ear to the top of the eyebrow, to the tail of the eyebrow. And that is the line of your vessel. You can draw that in. And you know that that is pretty much the direction in which it travels. You peel back that fascia, and then there is that second layer of fascia. Now, this is that interfacial plane that a lot of people say is a useful place to fill because the product will stay in between the two layers. But in reality, to access this very thin layer is quite difficult, and it's very easy to penetrate. So I wouldn't advocate it, but you will see some textbooks or some injectors saying this is a good place to fill. And then you can see just at the lateral aspect of the corner of the eye, there is a further fat pad. Again, we call it superficial because it is above the muscle, but it is a deep superficial fat pad as opposed to subcutaneous. And below that, above the muscle, we then have a gap. So this is why it's really important that you don't go below that facial plane, because there is a direct connection above the skull to the top of the zygoma. So if you put your product too deep, it will drop and end up here and distort your face. And here we have your temporalis muscle. So I want you to see that it does not peel off easily. We're having to use a scalpel to remove it from its tight attachment to the bone. And because it's so tightly attached, if you go down needle to bone in this area, know that you are not going in a fat pad or on the bone. You're actually going to be injecting deep intramuscularly. Okay. And of course, there are vessels running. So these are your deep temporal arteries that are feeding that temporalis muscle. So dangerous area to go too deep if you're in that plane. When we do a gunshot to the corner of the eye, this is where the product sits. You'll have seen this technique, I'm sure. So they're putting the product on the bone, but actually remember it is going to be in the muscle, and there are vessels that you need to try and avoid. You can't come too low. You need to keep it high. Okay. Just to remind you what we saw in that anatomy, that there is a compartment, facial compartment, that if you stay above that superior temporal septum, your product will not drop down. If you go below, you have a risk of the product ending up where you don't want it to, because you don't have a compartmentalized product sitting, holding things up. These are areas that are prone to gravity. So unless you put the product in a compartmentalized area, you're going to get drift of the product. And of course, those vessels that we saw, so there is that main vessel that comes from the top of the auricle of the ear to the tail of the eyebrow, and you can see that you can draw it in, and there's superficial temporal artery branching out over the forehead. So when you are marking your temple, these are the superficial vessels that you need to be aware of that sit above that superficial fat pad. So now we're going to go on to the forehead. And again, I'm just going to talk you through the anatomy of this part of the face and the things we need to be careful of. So these are just your landmarks. I'm going to lift the skin there. And here you can see the superficial fat pad. And there is the central fat pad and the middle fat pad. Okay. You can see that they are separate, but we've peeled them all back together. And there is frontalis. The muscle is right there. So below the fat pad, right there. Okay. The vascular network is above the muscle. And this is also the area where the fat is lost. In this part of the eye, where those vessels come out, the vessels come out through foramen in the bone. So here they are deep. So you see I've had to lift the fat up to get to it. Okay, so that demarcation line is about 2 centimeters. So 2 centimeters from the orbital rim. Above there, the vessels are superficial. Below there, the vessels are deep. So you have to keep this in mind when you're looking at a safe plane to inject. So the safe plane then, if the vessels are superficial, is to go deep. But again, the muscle is attached to the bone. There is not a gap for you to fill. So you really have to scrape your needle as deeply as possible under the muscle to get the lift. And remember, of course, it won't be under the muscle, it will be in the muscle. Therefore, you will see the movement of the product with movement of the eyes unless you select that product well. So using a really thick gloopy filler in this part of the face will end up giving you distortions to the forehead. Just a reminder of that safe 2 centimeter line from the orbital rim. So not 2 centimeters from the eyebrow, 2 centimeters from the orbital rim. You can measure up, you draw a straight line. Above that, you want to go deep. Below that, you want to go superficial. Bearing in mind that if you go put a heavy product superficial here, you might drag the skin down because gravity is playing its part. Keep that in mind when you are deciding about what product and how you put it here. Let's just think not just about where we're going to put fillers, but let's think about those muscles in those areas. So frontalis, remember frontalis is actually part of a very big muscle called occipital frontalis, and it runs all the way back. And frontalis is the only brow elevator muscle. So it's the only muscle that lifts. All the other muscles in this area are depressors, or they pull laterally medially, but the only lifting muscle is frontalis. And it is the only muscle responsible for horizontal brow forehead lines. So if somebody has horizontal forehead lines and you put toxin in them, you will reduce their horizontal forehead lines, but you will also reduce their ability to lift. they will lift less. And when we try and create an arched eyebrow, what we're actually doing is depressing the central area, and the lateral area we spare, so it works harder to make up for the fact that the central area is depressed. So it is an optical illusion. We actually lower the central part, and this will sit slightly higher, which is why sometimes it doesn't always look natural when we do that. If you put toxin across the whole of frontalis, you will flatten the brow. Looks quite nice on a man, quite a masculine look, not such an attractive look on a woman's eyebrow. So then we have your corrugators, which pull the brow immediately. So they're responsible for the corrugation along here. That's why they're called corrugators. Then we have the two depressors. We have procerus and depressor supercilii, and the top of orbicularis oculi. So those two are brow depressors, and orbicularis oculi, of course, is a sphincter muscle, so it pulls everything in towards the middle. So you get downwards and inwards, downwards and outwards, just downwards. Okay. And this is also the muscle that is responsible when people get those vertical eyebrow lines from constant frowning. That's because it's the orbital part of orbicularis oculi pulling in. So that's the anatomy and the aging and the danger areas. Now we're going to talk about when you see a patient and you want to assess what you're going to do. How do we decide? So assessment of the temple, well, of course, we want on the temple not to have a hollow, but we also do not want a bulge. It is not normal to have a convex curve. We want it to be flat. And obviously we don't want it to be concave. So children, because they're chubby, will sometimes have a convex curve. But actually in an adult, we want it flat or slightly, a slight dip. We don't want a deep dip, and we don't want a deep bulge, a big bulge. So you also notice that when you lose this, you lose the tail of the eyebrow. Tail of the eyebrow becomes less visible. And that is one of the most attractive features on anybody's face, is to be able to see the whole of their eyebrow. So if you shorten someone's eyebrow, it makes them look older. So one of the reasons why women often pencil their eyebrows in higher is because that concavity takes the corner of their eyebrow away, so they put it in higher where it can be seen. But we can, with filler, bring out that dip so that the eyebrow frames the whole face. When you have a deep curve, we call it skeletonization of the face, because you can actually see the skeletal bone shape. It's not an attractive look. So drawing in those surface landmarks, I'm just going to run the video because drawing them in is very important. So your lower landmark is your zygomatic arch. Okay, pretty straightforward. Your lateral orbital rim is the medial part of your temporal fossa. Okay, the temporal crest is where you draw in the upper part. And we use your hairline as the arbitrary posterior margin of your temporal fossa. Knowing the temporal fossa is actually much bigger, but this is the visible, what we call the aesthetic temple. Okay. Eyebrow positions. This is a really important thing. On a man, an eyebrow position, when you're assessing them, should actually overlie the orbital rim. It's an attractive look. So if a man's eyebrows sit higher than their orbital rim, we think they look less masculine. Okay, so you can immediately see then, if you actually flatten a man's forehead by taking away his horizontal forehead lines, it does not look unattractive at all. In fact, it's quite a sort of a handsome look to kind of have this flat eyebrow and a masculine sort of aesthetic to the face. For women, We prefer an oblique angle, and it sits above the orbital rim. So we have fat and flesh above, below the eyebrow to hold the orbital, to hold the eyebrow above the orbital rim. Okay. And this is probably one of the most important slides. If you want to alter somebody's eyebrow position, if you actually want to lower somebody's eyebrow for whatever reason, if you think their eyebrows are sitting too high, and sometimes if somebody's had a bad brow lift and they've had their eyebrows positioned incorrectly from surgery, putting filler above the eyebrow pushes the eyebrow down. So putting the filler above the eyebrow pushes the eyebrow down. Putting filler under the eyebrow lifts the eyebrow up. Or if you've lost this fat, you can go actually directly under the eyebrow and just project it forward. So that can often look quite smart on a man's face, because if they're just sitting flat, you can give them a slightly hooded look, which is quite handsome. And on a woman's face, if you want to elevate the eyebrow, you actually have to put the filler underneath the brow. So that's what you want to do. So you'll get more flesh in the area, but you will also get lift. And let me just recap that your muscles that pull inwards are the ones that cause the corrugation, and you need to get a balance between your brow elevators, your brow depressors, and the filler. It's a combination of muscle and fat and how it distributes to give you a youthful look. So how are we going to do this? Let's look at some techniques. So temples, you may have seen these techniques before. They're quite commonly advertised or quite commonly seen on injection trainings. Gunshot technique, going up and out and creating a stretch. Remember, you'll get more of a lift if you actually do a gunshot below the corner of the eye. So you have to push the skin up, palpate, and find a spot to be able to lift from here. If you put the filler above the eyebrow, you won't necessarily get a lift, but the skin will come out. So the tail of the eyebrow will become more visible. So putting the filler here makes the tail of the eyebrow visible. Putting the filler here elevates the eyebrow. And of course, using a cannula in that subdermal plane with an entry point. So we've drawn in that aesthetic margin. We draw a straight line across the zygomatic arch, because that is the lower border, and 50% of the way along, halfway through, is a nice safe entry point for your cannula to run in the subdermal plane. So I'm just going to show you how we inject under the eyebrow. So entry point at the tail of the eyebrow, needle to bone. We are going deep. We don't go superficial here because the product will end up in the eyelid. The skin is too loose. You're running deep, as close to bone as you can, and you're aiming for the roof. That retroorbital fat is there. This is what you want to lift. Some people, if they have an A-frame deformity, will go further, but can you see that's where the product is sitting? On the lateral third of the eyebrow to give it elevation. And if you see, she's fuller, but she's also lifted. And you can see that if you draw a straight line, the position of the eyebrow has elevated. Okay. I'm going to show you exactly the same technique, but now with a cadaver. Okay, so we are going, that's where we're going deep. Can you see we're underneath the muscle? So in the cadaver here, they've put the filler all the way to the corner. You don't need to do that unless somebody has an A-frame deformity. The reason we're showing you this is because if you go all the way to the corner there, you're going deep intramuscular, the roof is here, and that's where those vessels come out. Your supraorbital, supratrochlear notches are palpable. So your supraorbital pedicle and your supratrochlear pedicle, you will be able to feel the two little notches. You run your finger along there, you can find them. And you can see that you have to use a cannula because if you use a needle, you'll go through them. So this is how it's done, cannula deep, all the way across. So we're looking now the same thing, but from above. So there, this is the forehead. There's the eye. Product is running under. A little bit of dissection showing where the cannula is sitting. And the injection product is in blue. So you can see that if you run it, you can run it close to those vessels. Same again from a different angle. I want you to be sure that you know we are deep. The further medial you go, the greater the risk. You need to use a cannula, not a needle, because you're much less likely to cause trauma. And the idea is that if you fill the lateral third, only the medial if they have an A-frame deformity. And once you put the product in, it just needs a very smooth massage. Don't press too hard. Don't want to change the position of the product. You just want to flatten it. So it's a very gentle massage. And they will be fuller, but they will also be more elevated. And you can see there, the product sitting where you want it. So it's an advanced technique. You can see that it sits either in the roof, if you go that far, or it is deep intramuscular. So you need a product that will move with the eye. Okay. Showed two videos of that, one on a live patient, one on a cadaver, two on a cadaver, so that you can actually see that we are going deep. If you go superficial, the product will end up in the eyelid because the skin is loose. Keep that in mind when you are planning these treatments. Actually, to me, the easiest way of lifting a brow in the first instance is to use toxin. And as ophthalmologists, we do chemical brow lifts all the time as part of what we do. So a chemical brow lift, simply put, targets just the depressors of the eye or the eyebrow. So the depressors, we said, are not frontalis, because frontalis is the only elevator. So we leave frontalis alone. And we want frontalis to work as hard as it can. And to allow it to work as hard as it can, we knock off all the depressors. And how do we do this? So we treat the corrugators, we treat procerus, and we actually treat right down to the base of procerus, because sometimes when somebody has got a really heavy brow, they end up with a deep line here. And the only way to relieve the pressure of the skin and muscle on that line is to put your toxin slightly below so you get maximum pull. Maximum pull of frontalis whilst procerus pulling down is stopped. Remember, it's a balance. Okay. Depressor supercilii, which is right in the corner here and pulled downwards and inwards. And then all the way along the top of orbicularis oculi. Okay. And you will get something like this. So you can see, if you ask the patient to close, actually the best test to say to them is close your eyes tight. So you get them to use the top of orbicularis oculi, and you mark every single point that orbicularis oculi is pulling in. You get them to frown and you mark below their horizontal nose line, where your supracilii muscle is pulling in, and where procerus is puckering the skin. And you literally go little, and remember, these are things we want to stop the skin from moving, so we go superficial. This is not toxin to debulk a muscle, it is to stop the muscle pulling on the skin. So you don't have to go deep, you literally just go intradermal, subdermal with your toxin all the way along. Remember, if you go too deep here, orbicularis oculi sits above frontalis. So if you go too deep here, you'll knock off some of frontalis. You want to try and knock off as much of the top part of orbicularis oculi without affecting frontalis. And then what happens is the downward depressors stop working, and your frontalis, even just with its natural tension, will keep the eyebrows up. So there is less tendency to lift because there is already some tension on the skin. Just a reminder of the forehead injection points. If you are going in below the 2 centimeter line, you're going superficial. If you're going above the 2 centimeter line, you're going deep, because these are the areas that have less blood vessels that you are less likely to get into trouble. And then, of course, if you've done all that and you've put toxin in the patient and they still have horizontal forehead lines because of the tension on the muscle, so she's had her Botox, she still has these horizontal forehead lines, and she still has bossing, that dip in the center fat pad, then you can take a very, very soft filler like RHA1 and intradermally blanch all of these fine lines. So you just go, it's painstakingly slow. Just to do an area this size will take you about 45 minutes because you're putting micro droplets along the etched lines to airbrush them out. But you can get a very smooth result with a combination of toxin and filler. Toxin to lift, filler in the horizontal brow lines, and filler in the volume lost area. So they're the techniques that we use to complete the face so that we don't end up with a youthful mid-face and an old forehead, or a youthful under eye and an old eyebrow. And we have to choose the right product. So remember that your natural hyaluronic acid is a 3D chain of long HAs. Okay, and they're natural and they draw water and they move normally. But because obviously your natural HA is not cross-linked, it degrades and is replenished. We just replenish it slower with age. Natural HA is highly dynamic. It moves with your face. That's why it looks so glossy and natural. Most modern monophasic gels that you buy have a high degree of modification to help them last longer. So they have BDD cross-linking, the chains are shorter, so the product is stiffer. So if you put it in that subdermal plane, it does not move naturally. And we've all seen, I shared some celebrity video pictures in my last talk of weird looking faces, of really well-known weird looking faces where the product is just clumped up in their face because they haven't used a natural product, because the structure is so rigid. And then if you pick the right product for the right part of the face, with these products like RHA that have long chains but move like a normal face is supposed to move, because they are resilient to the movement and they are dynamic, so that they move naturally but they don't break up, because they have longer chains that behave more like your natural hyaluronic acid. And all of those techniques I showed you, there is a product in this beautiful portfolio of products that we have access to that you can use for each of those treatments. So if I'm doing intradermal blanching for the forehead lines, intradermal blanching for the crow's feet that you've already treated with toxin, but they're still etched in the skin, you can use RHA1. And RHA1 is also my filler of choice for treating temples. Entry point, cannula, really nice smooth finish. It's very soft, it integrates very easily, and there's very little swell to it. We don't want swollen, bulky temples. If you're going deep on the forehead, my product of choice is RHA2. Obviously, we're going deep onto bone. There are people that will use RHA3 and 4, but remember, we don't want to give somebody a really curved forehead. We want to take away the dip without making them look like a Neanderthal. You know, we don't want this really heavy brow. So I use RHA2. It's a beautiful product. And remember, because you're going deep intramuscular and the muscle moves, it is a more comfortable product for the patient. There is less stiffness of the muscle. Going into the roof with that cannula, the only product for this part of the face is Redensity 2, as far as I am concerned. You use about 0.2 of the product on each side for that A-frame deformity, 0.3 if you're also doing the lateral eyebrow. Gunshot technique, you can use RHA4 because it's a big space to volumize underneath there. Okay, because you're trying to create improvement to the superficial fat by treating the deep fat. So you really want to push the tissues up, which is why in this part of the face where the hollow is deeper, you can use something as bulky as RHA4 because it is a deep volumizer. Okay. And how does that all pan out when you treat? Well, when you actually harmonize the whole of the area, these are the kind of results you can get. You can use toxin for the eyebrow. You can use filler for a lateral canthal lift. We showed that in the last webinar. You can treat the mid-face and even the brow. And if you bring out that corner of the eyebrow, look how better the face is framed when the corner of the eyebrow is visible. That deep line on the nose, by treating with toxin to smooth and elevate, and then using your RHA2 to take away the dip on the forehead and airbrush out some of the residual fine lines. You get this completely harmonized face where you really can't see where one part of the face ends and the other begins, because that's what gives natural, youthful looking contours, that you don't just treat one little bit, you blend it into the next area, and you end up being able to, with this incredible portfolio of products. You know, I point to my own face when I do these talks because my face is full of RHA, and you can get all of the blending done and not have these deep demarcations that give away the fact that somebody's had filler. We do have a third webinar planned in this series. It's hopefully going to be a little bit different, because we're going to talk about the differences between men and women, because most of what we do is women, but there's a lot of men that like to have their faces done, and we don't like feminizing a man's face or masculinizing a female face unless that's the brief. We're going to talk about complications. How to avoid the vascular and the overfill. We're going to go into that in some great detail. I've been practicing for 21 years. I'm going to show you lots of complications that I've come across over the years and how we can avoid those. It's nice to see the best and the worst of treatments. And we have some local experts who will be sharing their cases with you. All of the techniques we've discussed, but on Asian faces. I hope you found that interesting. I'm hoping that you're going to send some questions, because we're going to discuss anything you want to add to your learning. Ask the question and we will go through it. Thank you.
Thank you, Dr. Tahera, for your very generous sharing, as usual. I'm getting like personal messages from my friends who are in this webinar and telling me that they're learning so much from this webinar and also the last one. So I now would like to discuss some of the questions that we have. So far, okay, we have two questions. The first one is from Dr. Eaton. So he asked, what are your thoughts? This is with regards to when you were sharing about the temporal filler technique. So he asked what do you think about using a cannula, but the entry is from the temporal frontal junction?
So temporal frontal junction, I'm assuming he means up here. So interesting. So doctors who want to access the intrafacial plane, it is easier to do it from here because it is easier to get under the top layer of fascia. So you will see doctors do that from here if they're trying to do an intrafacial injection. If you want to go subdermal, I would suggest you go from here. The reason being it is much less painful for the patient to go from here. So if you're going in that subdermal plane, the access is very easy. You can get to every part that you want to without too much difficulty. This is the best place if you are going intrafacial. But make sure you use lidocaine for your entry point because it stings. Your patient will not thank you if you just stick a needle straight down there. Whilst here, because of the amount of flesh you have here, you kind of get away with it if you don't want to put any lidocaine in. I was recently in Asia doing some training in Thailand and we were in Bangkok and we were in Indonesia. And I was surprised to see everybody uses lidocaine pretty much for cannula entry points. In the UK, hardly anybody does. We're a bit cruel. I think you're all very kind there.
Yes,
I hope that answers the question.
I hope it does. So, okay, the next question. Oh, okay. So Ethan has a comment. So he says he used that frontal area so that I suppose what he means is he used one entry point to reach both the forehead and also the temple.
So I hear what you're saying. So you go down to bone and then you tuck under to do the forehead and you go that way. Absolutely fine. Do you know, I think the wonderful thing about learning any technique is you will find something that sits well in your hands and you will make it your own technique. I personally do not use a cannula in the forehead. I use a needle because that muscle is thin and so tight to the bone that I really think that cannula scraping under there, the patients really find it uncomfortable, whilst I think the needle tends to be less painful. That is in my own experience. I'm happy to be told differently in different people's hands. Some people are just gentler than I am, but I tend to do my foreheads with the needle. I tend to do my temples with a cannula. But if you found a nice little niche where you can do both with one, that's a clever trick.
Okay, so Dr. Tahera, just out of curiosity, so when you mentioned that you're using a needle and you're using a product, a HA product on the forehead, would you, I mean, based on your vast experience of, using various fillers from different brands, would you say that there is a difference with the different fillers that you choose with using a needle? Would it be like a micro droplet technique or would it be like a bolus or a small bolus?
So it really depends on your assessment of the patient and how much fill you want. Because the tissues are tight, the product is going intramuscular, and and most of my patients are women, because most of them are women, not all. The last thing you want to give to a woman is a heavy forehead. It looks awful. So a man with a heavy forehead doesn't look quite so bad, although nobody wants to look like, their forehead is sticking out. But to get rid of that dip, I go needle down to bone. I actually almost use it like a cannula, but I do it with a needle so that it runs as deep as I can, close to that supraperiosteal area, and I just feel like I get deeper because I have a sharp edge rather than a blunt edge. And I run the filler in that space. Okay. And I use RHA2 in most of my female patients because I do not want bulk. It hydrates. I undercorrect because RHA2 hydrates beautifully, so I don't need a lot of product. And remember, it is a mobile area. The patient is still moving their forehead. The product is going to be trapped in the muscle. It will move with the muscle. So if you use another type of product that is not as happy being moved around, that will clump up when it's moved around or will bulge or look visible, that's why for me, if you're putting any product in an intramuscular plane, you think it's going under the muscle, but there's no fat pad, so it must be going in the muscle, whether that's orbicularis oculi, whether it's frontalis, whether it's temporalis. You have to be very clever with your product choice because you're putting it in the muscle. No mistake. You're not going under the muscle, you're going in the muscle. The muscle is going to move, the product is going to move. Make sure the product knows how to move.
Okay, excellent, excellent. Great. Okay, thank you for that, Dr. Tahera. Okay, so I have another question here. So when one is thinking about treating the tear trough, the temple, and the brow, all three areas that you covered earlier, so 2 questions here. So when do you decide when to bring the patient back for a touch-up? And which of these 3 areas, which one, based on your experience, needs the touch-up the most?
So I always start with mid-face, indirect tear trough, including lateral canthus. I wait 2 weeks and I check. If the medial tear trough looks like I can get away without putting any product directly there, I will. And then the next thing I do is the temple. So then I do the temple, and if necessary, just the outer eyebrow.
Okay.
I wait 2 weeks, I look, and then I'll treat the forehead. That's if I'm not doing toxin. If I'm doing toxin, I will do the mid-face, outer canthus, and toxin on that first day. At 2 weeks, the toxin has already worked, so then you can assess better how much you need in temple and lateral eyebrow. And then finally, when they've got all the lift that they're going to get from the toxin, I will see whether they actually need horizontal forehead lens. Whenever I check at 4 weeks, I look back at what I did. But if I am going into a neighboring area, I tend not to go back to the first area until everything is done. So if the patient has planned, and most of my patients have what I call planned treatments. So when they first come in, we talk them through the aging changes of their face. And they say, you know, I hate this or I hate this. And we start it. And then when they come back at 4 weeks, I've already got in my mind, if they decide to have more, what the next thing is. And they will know and we will know. And I'll have told them, when you come back in 6 weeks or 8 weeks or 4 weeks, this is what we will do if you are happy to proceed. And my patients, what we have, I don't know if this is something that is common across Asia, we have a subscription model in my clinic. So my patients, so a number of my patients will pay a fixed fee every 6 to 8 weeks. So it'll be either a 2-month direct debit or a 3-month direct debit or a 1-month direct debit, depending on what they do. So that every time they come, we will do at least 1 syringe of filler. So if we've done their mid-face, then I will do 1 syringe, half and half of their temple. 4 weeks later, I'll finish their temple. 4 weeks later, I'll do, and it allows you to see what happened before. So for me, touch-ups are actually part of the treatment because it's just a progress. But if somebody has got just, all I want is my eyebrows lifting, when would I do the touch-up? Never before 4 weeks. And to me, perfection is less important, symmetry is more important. So if someone says, oh, I wish you'd done a bit more, but they're perfectly symmetrical and they are improved. So they started, I don't know, with a grade 4 temple, and they now have a grade 2 temple, but they're equally grade 2 and the tail of the eyebrow is looking, I'll say, go away and be happy, please. If they are uneven, then of course I will touch them up. Unless they are on, you know, what I really discourage my patients from aiming for perfection. I show them their before and after pictures so they see the progress, because people forget. They forget what they looked like 4 weeks ago. So showing them those pictures and saying, this is how you looked and this is how you look now. And you can be happy. And I call it my go away and be happy look, you know.
I like that look. Right, but interesting. That is quite a good business model, and to my knowledge, I've not heard of it in Asia. I'm not sure if other countries practice, but where I come from, I've not heard of this business model. So good one.
We
Thank
call
you for
it the
sharing.
rolling. We call it our rolling program. So they just, that's what we call it. Some people would call it a. I know there are some clinics in the UK that call it a membership. They say you're a platinum member, you pay £100 a month or £200 a month, whatever, and you're a platinum member and it gives you certain benefits, or you're a gold member. We have our rolling program.
Yep, definitely a good one for all the business owners who are attending today. Okay, for my next question. Okay, for someone who has never injected RD2, Redensity 2, and is injecting for the first time, what should they do and not do?
So if you're an experienced injector of the periocular area, but you have used a different product to do tear troughs or different product to do the under eye, then I would say the learning curve is very easy. And you don't have, you will just put the product as you would the product you have in you, but you'll just be very pleasantly surprised how few side effects you get and how smooth and natural the product looks. If you are going for the first time in learning how to do these areas, so you're not a seasoned under eye treatment person, then I would say start by doing indirect, because you will know how to do mid face. If you're, for example, doing your very first eyebrow lift, you know, with something like Redensity 2, the secret is use a cannula, at least a 25 gauge, don't go too thin. Needle down to bone at the tail of the eyebrow, make sure you hit bone. When you go in with your cannula, make sure you hit bone. Lift the tissues, physically lift the tissues so that you know you are sliding under. And when you first start, don't go past the lateral third. Just keep it to the lateral third, so you don't go into the medial 50%. If you're a bit scared, understandably, because remember there are lots of vessels there, palpate. You can very easily put your finger on the orbital rim and palpate your supratrochlear notch and your supraorbital notch. Mark the notch and don't go past that. You will be, if you run your thumb just under, you can feel them. Supratrochlear notch.
Yeah, I can feel mine. Yep.
Yeah, everybody can.
Yep.
Supraorbital, keep lateral, and you'll be as safe as houses.
So always use cannula size.
At least, so cannulas come in lots of sizes. A 27 gauge cannula is the thinnest one that we can get in the UK, and maybe you can get a 30, but they are really, as even though they have a blunt end, they will penetrate almost through tissue almost as well as a needle will. The bigger the cannula, the harder it is to penetrate a vessel, but the bigger the cannula, the more product you will deposit. So it's a balancing act. So a 27 gauge cannula, sorry, a 25 gauge cannula will need a 23 gauge blue needle entry point, and the 25 gauge cannula has usually got an orange hub to it. And it's a nice in between, that enough product, that there's not too much product coming out, but you have enough thickness to the cannula that you are less likely to enter a blood vessel. So I use a 25 gauge cannula to do this. To be fair, sometimes I will use a 27 if I think it's tight area, but then I will not go past the medial aspect because they are the danger points. So if you are just staying lateral, you can use something as fine as a 27. You'll get a little bit more control.
Okay. Okay, thanks for sharing, Dr. Tahera. Okay, so the thing is, I have 9 questions more, but I only have about 10 more minutes of your time.
So I'll try and keep my answers short because I tend to talk too much. Let's whiz as fast as we can.
Okay, so the first question, if my patient did not walk in for a brow lift specifically, but as a doctor, I noticed the brow deficiency and the volume loss. So how do I talk it through with my patient to make them see that?
So it's a difficult thing because on the one hand, your patient might have come in asking for something around their mouth and you think their brow. I usually ask the patient, is this the only thing that concerns you? Or do you want me to talk you through the aging changes on your face? And if the patient says, no, I just want my lips done, that's fine. If they say, no, I'm really interested, and then I'll say, I might end up pointing out things that you have not noticed. Are you comfortable with that? And they say, oh, yeah, tell me. Then I'm away. I'll start from the top and work down, and I'll talk to them about and I'll always say, let's start with your mid-face. We'll do this. We can blend this way, and you can blend this way. And most patients, I'll do mid-face and blend downwards, mid-face, and they end up on a rolling program over an 18-month, 2-year period. And I always say it's a work in progress. So that's how I approach it. I ask them if they're open to suggestion before I start picking fault with their face, because I think it's very rude to just pick fault with someone's face. They may not be in a good headspace to take it.
Thank you for that advice. So, okay, the next question. What do you do for deep forehead wrinkles, the deep ones?
So if they have, assessing foreheads, the most important thing is to look at the eyelids. Most people who have deep forehead lines have them because they get reflex lifting of their brows because they have heavy skin on their eyelids. So, and then if you put toxin in, you just make the eyelids more heavy. So if somebody has really deep lines, you need to assess the skin on their eyelid and decide whether if you put toxin in there, it's going to make it worse. If you think you're going to make them worse by treating frontalis, I'll do a chemical brow lift with the toxin as I've described. I'll then give them a little bit of brow lift with filler, if that's appropriate. And then when I have given them as much elevation as I can, then what's left of their forehead lines, because remember their forehead lines will diminish. If you lift them from here, the muscle doesn't have to work as hard. So the lines will look smoother anyway. When you've done the chemical brow lift and the filler brow lift, I will then, across those horizontal brow lines, I will fill with intradermal blanching. I will fill the furrows so that at rest they look smooth. They will still have movement. If it's a man, I'll often say to them, you'll look good with a slightly heavier brow, and I'll just knock him off.
Okay. So, okay. So I think the next question, somebody was not clear. How did the fillers on the temple actually migrated to the zygomatic area? So how to prevent that?
So if you go in the subdermal plane, they will not migrate because you have a compartment, you have a sort of a ligamentous attachment that stops the product going. If you go deep, so if you're trying to do an intrafacial treatment, or if you're going needle down to bone and you don't go deep enough, so you're not on bone, you're in mid-air, there is a space above the temporalis muscle. So just above the temporalis muscle, below the fascia, there is a connection between your, so if you, on a skull, you'll see, won't you, that you have the zygoma and then there's a gap above and a gap below. So that is actually a real space in your face with tissues above and below, and there is a gap in between and above temporalis. So if you're putting product above temporalis, but it is not trapped under the skin or it's not trapped between the fascia, but it is still sitting above temporalis, it will drop. So you either go deep under the muscle or intramuscular, or you stay superficial above the fascia, because then you've got the attachment of the fascia to stop the product from dropping.
Understand. Okay. So basically either go subdermal or go deep enough to go beyond the muscle or
Deep
intramuscular.
Yeah, either beyond the muscle. And if you are very experienced and you go intrafacial, that's fine. But if you are not at that point on your learning curve, stick to layer 2 just under the skin or right the way under the muscle.
Okay, got it. So because we only have 5 more minutes, maybe I'll just select the some of the questions. Okay, so a question from Dr. Aida from Indonesia. Hi, Dr. Aida. So she says she saw that you were using RD2 to fill up the roof of the eyebrow. And she's asking whether the lift capacity from RD2, is it enough to lift the eyebrow? And whether can she use another skew?
So lift capacity of RD2 is actually surprising. It's only 15 milligrams of HA, but because of RD2, the way it's constructed, that manufacturing process, it has more lift capacity than you would imagine. Of course, there are products with more lift capacity, but most products with real lift capacity also bulge because they draw in a lot of water. So the last thing you want is a bulgy eyebrow. Okay, you don't want these tissues to overlap. That's why I use RD2, because you don't get bulge. You need a tiny amount of RD2. So if you're putting in something thicker and bulkier, you're going to need even less. And it's very hard to control that tiny quantity. You'll either end up undercorrecting or overcorrecting. With RD2, you give just the amount of correction you want, maybe about a 5% undercorrection, if anything, and you stop. You can see what you've done straight away, and you know it's not going to look significantly different in 2 weeks. Most other products will not give you that same correction at 2 weeks.
Okay, understand. So you recommend RD2 because of the expectation?
Yeah, you don't need that much lift because this area is so small. The lift capacity is enough for RD2, and it will not bulge or hydrate and give you that heavy browed look.
Okay, so the last 2 questions. Okay, question from Dr. Patita. So she asked whether if she were to use the Botox to lift the eyebrow, is he or she targeting the intradermal, or will it be the intramuscular layer for the eyebrow?
So in this area, if your patient is over 40, there's not that much difference, because most of the subcutaneous fat, unless they're very chubby, has gone. You are actually going intradermal. And the reason is because, remember, your muscle has fibers that hit the skin. If the deeper you go with your toxin, the more you need, because you really just need to lift the skin. You don't actually need to stop the muscle from moving. You're not trying to debulk the muscle. You're not trying to stop the actual muscle movement of the function of the eye. You literally just want to stop where it's pulling on the skin. So my top tip for toxin for facial lines is keep it superficial. Unless you're trying to debulk the muscle, keep it superficial. You'll use less toxin and you'll get smoother results, especially in this area.
Okay, good one. And then the last question from Dr. Henry Tanajo. Hi, Dr. Henry. So she said, thank you very much for the excellent presentation. Any tip for A-form or upper eyelid hollow treatment?
So that A-frame deformity is deep to bone, but don't stop here. You go all the way. You are then, tip of your cannula is very close to supratrochlear. Yep. But you stay, if you remember the vessels are going vertically, you're coming horizontally. The chances of you doing you're not going to cannulate a vessel. You keep your cannula steady. You stay close to the muscle. I actually put my thumb on the supratrochlear notch, a finger, and I keep the cannula just lateral to it. And then I run a very small droplet. You don't need a lot of product. You'll get beautiful results if you do it, but it's stay deep, otherwise the product ends up in the eyelid. The fear of hitting something often makes you want to go superficial, but that's the worst thing you can do, because then you get heaviness to the skin being dragged. But if somebody has an A-frame deformity, you only have to get one right and you'll be really confident. And you don't need a lot of product, Dr. Henry. You'll manage it, I'm sure.
Okay, so thank you, Dr. Tahera, for the excellent webinar. Do you have any other final words for this session today? Closing remarks?
I think the main thing is that just remember, don't just concentrate on the under eye. Make sure that you blend everything. Blending, blending, blending. Keep all the contours smooth, because that will give you the best result. I know that's more expensive for your patient. It's a longer journey for your patient. But if they are committed to looking youthful and investing in their faces, they won't mind. And having something like a rolling program, or say, I'll do another syringe in a month, and trusting them to come back because they like what you do and they won't go to someone else. I think that you will be able to get all of these fabulous results. And combine treatments.
Yeah,
combine treatments.
So thank you so much, Dr. Tahera. And today we explored, as a recap, we explored advanced dermal filler techniques for rejuvenating the eye, the temple, the forehead, and the eyebrow. And I would say, personally, for me, the most epiphany moment was particularly on how important the location of the eyebrow is to affecting how we look in general. So that's why women pay so much to get their eyebrow embroidered and things like that. So for me, it was enriching, and I'm sure it was enriching for the rest of our participants. Thank you so much, everyone, for taking time to join us today. And with that, I would like to end the webinar, and do mark this date down on your calendar, our next webinar, where Dr. Tahera will be sharing some of the results that she have, and what are the adverse events that you can get from periorbital rejuvenation, and some of our Asian doctor experts will be sharing on their cases for Asian cases for periorbital rejuvenation. Thank you so much, everyone, and good night. Thank you, Dr. Tahera.